Okay, hello everyone, and thanks for joining. I'm Walter Proper, the IAPHL Executive Director, and I'll be moderating today. And this is our webinar on our health supply chain supporting people living with non-communicable diseases. As those of you joined know, that we are going to do a half-an-hour webinar, and then this will be followed by a moderated discussion on the IAPHL listserv, so members can join in, and if any questions that are unanswered today, we will be able to answer those also on the listserv. So without further ado, I will introduce my longtime friend and colleague, Marilyn Noguera, who is the Senior Supply Chain Officer for Non-Communicable Diseases Program at PATH. Since 1998, Marilyn has been working to strengthen supply chains around the world in 21 countries, Africa. She's worked extensively in Africa, Latin America, and the Caribbean. She currently provides senior leadership and technical leadership in the country and global efforts to improve non-communicable disease commodity security. So thank you and welcome, Marilyn.
Thank you, Walter. So for those of you who have not heard of PATH before, we're a US-based NGO and a global team of innovators that work on many fronts to eliminate health inequities. Next slide. 20 years ago, PATH started working in NCDs, and we've worked in more than 10 countries and globally along 5 focus areas. Supply chain strengthening is one of them. Most recently, we've completed NCD supply chain assessments in Ghana and Kenya that we're going to tell you about today. We're also developing an NCD forecasting tool for essential medicines and products. Next slide. NCDs are a global problem. The primary NCDs that you've probably heard about or even have people in your family who live with these are cardiovascular diseases, hypertension, diabetes, cancers, and chronic respiratory diseases. 71% of all global deaths are due to NCDs. That's 41 million people every year. 75% of these deaths occur in low and middle income countries. And I think we all know that COVID has been a big threat for people living with NCDs. NCDs make people more vulnerable to becoming severely ill and also at added risk for complications from the disease. There really is significant unmet need in terms of screening and diagnosis, treatment, and then control of the disease. Next slide. Even the Sustainable Development Goals support investing in NCDs. For countries, there's a pretty clear policy imperative to reduce premature deaths by 1/3 through prevention and treatment of NCDs. Next slide. But to achieve SDG 3.4, NCD supply chains need to deliver, and they're not. The WHO Global NCD Action Plan sets a goal of 80% availability of the affordable basic technologies and essential medicines, including generics, required to treat major non-communicable diseases in both public and private facilities by 2025. For many of you, a goal of 80% availability by 2025 may sound a bit timid because you're used to working in full supply, donor-supported programs like HIV, malaria, TB, and family planning. But achieving the 80% availability benchmark by 2025 would be an enormous achievement for most countries and significantly improve the availability and affordability of medicine for people with chronic, life-threatening NCDs. Next slide. When we talk about the NCD supply chain, depending on the country, we're talking about essential drugs, we're talking about insulin and the syringes and needles needed for administration. We're talking about devices and consumables for blood sugar monitoring that are needed for safe and effective insulin self-administration. And some countries are beginning to work on smoking cessation, which often is aided by new products that need to be introduced into the supply chain, like nicotine replacement therapies. Often these different products are managed by separate supply chains that do not deliver them to the one place where the patient goes to resupply. Some items like insulin-associated products need to be purchased in the private sector because the public sector does not currently provide them. National health insurance schemes rarely cover the cost of insulin-associated consumables. And rarely are NCD commodities the subject of annual quantification exercises or full supply funding or funding gap analysis. And this severely limits commodity security for people living with NCDs. The essential medicines are often rationed, even though they're for chronic conditions which require adherence to treatment regimens. So PATH, with financial support from Access Accelerated, set out to learn about the NCD supply chains in Ghana and Kenya. Next slide. We collaborated with our NCD counterparts in the Ministries of Health of Ghana and Kenya to answer these 3 questions via supply chain assessments. Are medicines available? Are they affordable? And what can be done about it? Each country selected 6 tracer medicines from the list you see on the slide on the right that focus on hypertension and diabetes, which are priority NCDs, but some countries included cancer medicines or respiratory drugs as appropriate. And the data for these medicines was collected via site visits and key staff interviews at the locations you see on the slide. You will be hearing directly from my colleagues in Kenya and Ghana, who are going to share with us some of the key findings from their supply chain assessments. Thank you. Next slide.
Thank you, Marilyn. And again, if you do have any questions, you can put them in the Q&A and we'll look at those at the end of the presentation and answer them. So now I'd like to introduce Williams Kwarah. Hopefully, Williams, I didn't butcher your name, is the M&E and data manager of the PATH Non-Communicable Disease Program in Ghana. He has over 15 years experience working in public health, and he's been utilizing analytics for decision-making. He's led the Ghana NCD supply chain assessment. So welcome, Williams.
Okay, thank you very much, Walter. So just like Marilyn had indicated, Ghana, the picture for NCDs is totally not different from what we see globally. And so we have a situation where between 30 to 40% of adults live with hypertension. And there's a 21% probability that people between the ages of 30 and 70 years are likely to die from CVD, CRDs, cancers, and then diabetes. And then you would realize that about up to 12% of the adult population in Ghana are diabetic. Next slide, please. Yes, so as part of our efforts to try to support the ministry and the Ghana Health Service to improve supply chain for commodities essential for managing these conditions, we carry out an assessment. And we essentially wanted to see the availability of these commodities at the various levels of service delivery. So from this chart, you would see that at the horizontal axis are the various different categories of health facilities. So HC is health centers. They are the lowest level, primary healthcare level. We have DH as a district hospitals. That's a second upper layer, together with the faith-based organizations. These are mostly religious hospitals. And then we have the private sector hospitals, the quasi-government hospitals, and then the regional hospital at the top level as the secondary level. And so we wanted to find out how many of these facilities do have these commodities, and that is what is measured on the vertical axis. So clearly you can see from this chart here that the primary healthcare level facilities, the health centers, are actually struggling having the basic commodities that are used to manage these conditions. And then you move on to the second layer where you are looking at the district hospitals together with the faith-based or private hospitals. And you realize that the district hospitals, which are largely owned by the government, are actually struggling. None of them are making up to the 80% availability goal as at the time we collected this data, which is early last year. However, the private And then the faith-based hospitals are doing somewhat well with some of these commodities. So you look at amlodipine 10 milligrams, you look at metformin 500 milligrams, you look at salbutamol inhaler just for the respiratory conditions. You will see that the faith-based organizations are doing much better. Now you look at the secondary tier where we're talking about regional hospitals at the far end, where most of these conditions are referred to for much proper management. And one would expect that most of these commodities should be available at that level. Clearly from the charts at the far right, you will see that only amlodipine 10, and then we have premix insulin, and then salbutamol are available and making the benchmark. The rest of the commodities we looked out for did not actually make the benchmark, and really some are very far from making up this benchmark. This simply tells us that a lot of these people who will not have access to these medicines at these facilities are then driven to the private retail pharmacies where they have to buy these commodities at higher cost, clearly increasing the economic costs in managing these conditions. Next slide. Yes, so in Ghana, we have two categories of people who seek these health services. We have those who are registered with the National Health Insurance Scheme to be able to access healthcare services through their cards, and then those who do not have health insurance. So about 40% of Ghanaians are covered by the health insurance scheme. We do have private health insurance schemes who are not accounted for here. And then we looked at the facility level. The chart on your right tells you, if you make a comparison of those who have insurance and would probably get access to these medicines versus the prices that are being sold, we wanted to see how many of these commodities per facility are sold at prices that are more than what the health insurance mandates. And clearly you'll see that for every commodity, there is one or two facilities that would sell a commodity that is higher than the health insurance price. And I'm referring to the red bars. You see that amlodipine 5 milligrams, for instance, we have about 6 facilities out of the total that were assessed that would sell commodity amlodipine at a price higher than what the health insurance is asking for. You see for bendrofluizide, there is also some facilities. So clearly, you will see that at every level, at every commodity that we looked at, there are instances where people would have to either top up money to be able to have access to these medicines or not. And so you put all of that together and you look at the price markups at this public sector, you realize that they were very high as 1,200% price markups for some of these commodities. What this simply means is that it puts a lot of burden on clients who, one, do not have health insurance and will need to go and buy these or have to top up to be able to get access to these medicines. And then also, you would see that facilities that do have these commodities, once they run out of these commodities, then it becomes another big issue that clients would have to move into the private sector to be able to secure these drugs. Next slide. So here we looked at, so moving from the public sector, looking at the hospitals and then the private hospitals, we looked at the retail pharmacy to see what happens there. And clearly from the chart on your right, you would see that all of the commodities they sell out there, all the prices are way off the health insurance mandated prices. What this simply means is that if a private pharmacy is not accredited with a health insurance and clients have to secure their medicines from these places, they are going to pay higher prices. Interestingly, what we see is that because the unit price of these commodities is already high, their price markups are quite low. So we could have as low as 80% of price markups that are being added at the private retail pharmacies. And then you look at just a few commodities are being sold at prices that are less than what the health insurance is mandating. And that is just amlodipine. And then we saw that in insulin, premix insulin. So clearly you would look at, we realize that the markup prices at the regional medical stores are quite low. And then if you look at what is happening at the private sector, the retail pharmacies, they are quite low. But then you look at the unit cost of these medicines and you see that they are really high compared to what we saw at the public sector. clearly that means that there is a problem. And the problem is that people who would have to rely on the private sector for these commodities would have to spend more to be able to get their commodities. Next slide. So putting all this into one pot, we realized that there was a need to make up certain recommendations that would move, that would compel the government and then the ministry to work out a way to be able to improve access to these commodities. So at the end of this assessment, 9 recommendations were made, and these are currently being operationalized. PAF is supporting the ministry and the Ghana Health Service to operationalize some of these recommendations, and I'll speak about 3. The first one is to strengthen the leadership, governance, and financing of NCD supply chain. This is something that we feel would have a huge impact driving the country to meeting the 80% availability goal by 2025. At the moment, Ghana implements a framework contract system where the Ministry of Health would pull together suppliers, potential suppliers, bargain at very good prices for these commodities to be supplied to health facilities. We have made recommendations to expand this facility and make it more relaxed and expand the commodities, the number of different drugs that would be included into this particular facility, such that facilities even at a lower level, who by policy will not have to stock certain medicines, are able to stock to be able to provide refill purposes to people living with NCDs. Secondly, we are advocating for the digitization of the dispensing area services connected to the national platform where people who are getting medicines right at the dispensing areas, data is available and fed into the national GILMIS platform. If this is achieved, what it simply is going to do is that it's going to allow real-time visibility of the stockout rates and stockout management, such that people in authority will be able to see how the pipeline of these drugs are flowing, and then where the need is, they will be able to prioritize and move towards those areas to make sure that drugs are available for patients. And the third one is to also meet the unique requirements of insulin, which is a big problem. So at the moment, what we see in country is that insulin is procured singularly, so without syringes and sometimes without the glucose monitors or strips. And so patients would have to go, if for instance, they go to a health facility and they are not able to get these medicines, they have to go to the private sector and they just get a vial of insulin. It doesn't come with syringes. So then patients who do not have syringes or money to buy syringes, they have to reuse what they have. The advocacy is that let's bundle all of these commodities together, such that if you are making a procurement, you are bundling all of these things and you have everything in check to improve the administration of insulin and then to also improve the availability of these commodities to manage diabetes. So these are the commodities related recommendations that we have made. And currently we are working with the Ghana Health Service through the SFDM to make sure that these things are addressed and operationalized to improve access to NCDs in Ghana. Thank you very much.
Thank you, Williams. Next slide, Rachel. So I want to introduce Dr. Josphat Samoei, who has 17 years experience assessing and improving pharmaceutical supply chains. He has worked with the Clinton Health Access Initiative, CHI, and MSH in Sierra Leone and in Kenya. And he is currently, as it says, the supply chain specialist, the NCD supply chain specialist. So thank you, Josphat, for joining us, and it's over to you. And again, put your questions in the Q&A and we'll answer them, as many of them we can at the very end. Thank you.
Thank you very much, Walter. Yeah, so we also did the same assessment like Ghana, journey of the pill assessment. And as you already heard from Marilyn and Williams, we pretty much see the same picture in terms of the NCDs situation in our country, whereby you see NCDs contributing to morbidity and mortality being the second in the country. And of course, we see about 39% of annual deaths associated with NCDs. According to our STEP survey that was done in 2015, we also have an increasing prevalence of these NCDs. Case in point is hypertension, whereby about 24% of the population actually have hypertension. And also cancer of late has been on the rise, and it's a third leading cause of death in our country. Yeah, and of course, as documented, it's among the high cost impact in terms of household incomes, and our country being in the low and middle income category, it's quite contributor in terms of what goes into healthcare out of pocket expenditure. Next slide. Yeah, from the assessment, our country runs a devolved health system whereby we have two major suppliers, national suppliers, and then we have devolved units making decisions around financing, procurement, and actual supply to the facilities. So in that assessment that was done, we realized that only 43% of the facilities had all the tracer commodities that are required for NCD management, specifically for hypertension, cancer, and diabetes. So really, it goes to suggest that about 57% of facilities do not have the requisite mix of products for proper management of these chronic conditions. What also came out as a worrying trend was that in the period, you'd see close to prolonged stockouts. I mean, in quite a number of facilities, and you'd see this running beyond a month. For instance, with amlodipine, we had a median stockout of about 46 days, and for the hydrochlorothiazide, about 18%. And these are products that are meant to be available in the lowest levels of our care, the primary healthcare facilities. And again, I mean, this targets the low-income earning people of the population, and that is where we see a lot of challenges. Again, looking at the same commodities being out of stock, we also realized that 11% of the facilities actually had expired tracer medicines, which again goes to suggest the potential for improvement in terms of the supply chain efficiency. Next slide. Yeah, so in terms of the NCD supply chain, we looking at the other programs, NCD is coming from a very low point, and from that assessment, we discovered that in terms of documentation, yes, most facilities could show availability of delivery notes and then the stock cards. But again, when you look at whether these stock cards are updated and they are being used to make decisions, that was another story. And we actually, about 54% of the facilities had updated stock cards. Only 9% could show availability of evidence of orders that they placed in the past. And as I've said earlier, 43% only had all the commodities that were being assessed in that journey of the PL assessment. So this goes to show a challenge in terms of data availability and data use, and also can basically explain part of the stockout challenges that we see and the expiries, and points to supply chain inefficiencies that we'd need to increase our efforts towards addressing them. Probably pointing out to challenges with financing, the procurement and ordering, as well as any data logistical framework that should be in place in the country. Next slide. So as like the Ghana experience as well, we looked at the price markups for these tracer items and cutting across these three different sectors. For instance, public sector had fairly high variability in terms of the price markups, although a majority of the products were actually close to the 33% established country markup for the pharmaceuticals. Although we also saw some high markups to the range of 88%. Private sector was fairly regulated, but again, we still see high price markups. And was quite very high in hospitals compared to the chemists that are in the retail sector. For the faith-based, we saw quite among the highest markups, with 75% being above that 3% cutoff points. And I mean, we had some few access programs that contributed to special prices for patients, and this was mostly evident in the faith-based sector. Next slide. Yeah, so out of these assessments, we have been able to partner with the government Ministry of Health through a strategy that is meant to address availability of these NCD supplies. So out of this, we have a supply chain technical working group being steered by the government, and it's aimed at addressing these identified gaps all the way running towards 2023. And we started off in 2020 working around the supply chain oversight structures, the technical working group, and enhancing visibility for the NCD program, much to the level that we've seen with other established programs like family planning. And this year in 2021, the goal is to ensure that the service delivery and data for commodity management is available so that we are able to further enhance quantification for the NCD supplies. Next year would really focus on primary healthcare level in terms of promoting access to services and products at that level so that we increase the availability of these commodities. And into the future, we want to address those markups that was evident in that assessment, and we try to look at what are some of the cost drivers for the NCD supplies and what are these we can do to address access for the people living with NCDs. Of course, with the overriding goal of the WHO to make sure that 80% availability of affordable basic medicines and diagnostics for NCDs. Next slide. And so this came from the head of the division of NCD prevention and control, and pointing out that the assessment was quite timely in terms of helping them to make decisions and strategically advise the national Kenya Medical Supplies Agency and other stakeholders to ensure that NCD supply chain is actually enhanced better. Thank you.
I just wanted to conclude very briefly that at PATH, we see the importance of working along 4 key areas: forecasting, financing, procurement, and deliver. The ability of the supply chain to do those 4 things is key to really improving availability and affordability of these medicines. And so the first one, in terms of the sequence, where you start first, is really helping countries to be able to forecast their needs. Countries are not able right now to forecast what they need, and therefore they're not able to finance and figure out how to finance the medicines that those supply chains need to improve availability in a consistent way. So we're working on a tool, an NCD forecasting tool for essential medicines and products that we're going to be testing in Ghana and in Kenya and in Uganda in basically the coming months, and that we really look forward to sharing with IAPHL membership, and maybe in a future webinar, maybe in the next quarter, where we can share some of the experience with that. And we believe that in order to impact on financing, that's key to be able to then procure and do much more strategic procurement, get economies of scale, negotiate better pricing, and improve availability so that when people order, the supply chain can actually fill their orders and not ration, which then obviously impacts on the people living with NCDs. So for those of you who have been working in the health supply chains with HIV and malaria and other full supply products, you know the types of knowledge and capacity and processes and tools that are needed to make supply chains stronger and more able to deliver. So there's a lot of work to be done in NCD supply chains, but compared to 20 years ago, we also know what is possible and how to strengthen supply chains. So we look forward to meeting again, and thank you for your time today. Over
Thank
to
you, Marilyn,
Walter.
for the sum up. Yes, so again, just to be sure that we're going to continue this discussion and moderate discussion on the IPHL listserv. And as it says, you can join for free and become one of our 8,000 plus members worldwide. And as you can see, we've run out of time. I would say that a couple of the questions were sort of answered, that PATH is working on a forecasting tool, which they're happy to share once it's completed. And so there's about 9 questions, and I think we'll again take these, and these will all be answered on our listserv. So please make sure you're a member and join and look for the listserv. And our great presenters, thank you very much. Very interesting topic of non-communicable diseases and where we're headed with that and what we need to do. And I guess a couple people noted that it's quite a high target that you've all set for yourself and for the world. And we wish you the best of luck. And thank you again for the presenters, and thank you all for joining us today.